Hello, and thank you very much for having me again this year. We've talked extensively about edge-to-edge repair and orthotopic tricuspid valve replacement. I would like to talk to you a little bit about the heterotopic tricuspid valve replacement and a few cases of IVUS-guided bicaval valve implantation that we performed. So I have an 89-year-old male with a long history of moderate to severe tricuspid regurgitation. He wasn't really following up with his cardiologist and presented with worsening dyspnea and lower extremity edema and signs of right heart failure. In terms of comorbidities, had atrial fibrillation, CKD stage 3, and an IVC filter that was placed in the setting of pulmonary embolism and GI bleeding in the past. So he was diuresed and he was quite functional, his baseline, so we considered treatment for his tricuspid regurgitation. Here you can see the wide open TR and the coaptation gap, the no coaptation essentially, and the dilation of the right ventricle, right atrium, and the classic triangular shape of the severe TR. We proceeded with the TE for further assessment, and interestingly, one second, this has to play too. Okay, great. We found that the anterior leaflet was had some flail and prolapse there. That was probably happened some time ago, and that led to worsening remodeling of the right-sided cardiac chambers. So here you can see also in the 3D MPR, you can see the large coaptation gap, and you can see that the tricuspid valve actually appears to be quadricuspid, having like 4 leaflets, which poses additional challenges. So we screened the patient also for orthotopic tricuspid valve replacement. We did a gated cardiac CTA that showed that the tricuspid annulus was very, very large. The average diameter was 55.4 millimeters, as you can see. So this is the most recent landscape of tricuspid transcatheter therapies. We have devices that target the leaflets, coaptation devices. We have the orthotopic tricuspid valve replacement, some like annuloplasty devices, and also the heterotopic devices. This is, as we know very well, this is the disease progress of tricuspid regurgitation. The further down the disease process, the more severe the RA and RV remodeling, and the fewer the options we have to treat the tricuspid regurgitation, and this is very bad outcomes. So here we have a patient with severe symptomatic TR, elderly patient, large coaptation gap, very large annulus, high surgical risk. We also did a right heart catheterization after diuresis, and so preserved cardiac output without significant pulmonary hypertension. So we decided to offer compassionate use of the tric valve system, which is the bicaval valve system. So the tric valve system consists of 2 self-expanding valves, one for the SVC, one for the IVC. They come in 2 sizes, and they have the sealing skirts, as you can see. So the patient actually, in the meantime, was readmitted to the hospital again with volume overloads. He was diuresed again. He also had acute kidney injury, so we decided to perform the procedure in the inpatient setting. So conscious sedation, we used the transthoracic echo and fluoroscopy, and we decided, because of the acute kidney injury again and the fact that he recently received contrast for the CT scan, to use IVUS during the procedure for sizing of the SVC and IVC, and also to mark fluoroscopically the landing zones in an effort to spare the contrast. So this is the IVUS pullback. So we advanced the peripheral IVUS catheter over an 035 wire all the way up to the right brachiocephalic vein. We did a pullback, and this is what it looked like on the pullback. We as I will show you, we measure the key spots for the sizing of the valves and also the fluoroscopic marking areas. We also placed a Swan catheter in the right PA, which also helps with orienting us for the landing zones. So what we found is that actually the measurements we made at these levels with the IVUS correlated very, very well with the measurements from the CT scan. These are the SVC measurements, and these are the IVC measurements, which again correlated very well with the CT scan that was done a few weeks prior to the procedure. So based on these measurements, we decided to deploy a 25 millimeter SVC valve. You can see here how the delivery system went through actually the IVC filter without any issues. And the SVC valve was deployed. Then we proceeded with the IVC valve deployment. For the IVC valve, the transthoracic echo and the subcostal views are very important to make sure we have enough valve in the right atrium, but the valve is not too low, so we don't obstruct the flow of the hepatic veins. And you see we have a pigtail also in the hepatic vein. And this is the deployment of the IVC valve, the final release that you will see there, very stable. It's about 5 millimeters inside the right atrium. And here you can see how we use fluoroscopy also to mark the SVC confluence and the other areas for proper landing zones for the valves. It was very helpful. And same with the IVC-RA junction. We marked it with IVUS, and then we're able to land the valve exactly at that level without having to use contrast. So the patient was discharged 2 days later. Interestingly, at 1 month, he already had some reverse RV remodeling, and which was not seen in the Tricuspid study. Usually the patients that had reverse remodeling were a little later, like 3 months, 6 months. And the patient was doing much better in terms of symptoms and diuretic requirements. So this is just very briefly another case that we did actually the same way, and this patient had a dual chamber pacemaker with a right atrial and right ventricular lead. And what I want to emphasize here is we also use the pacemaker leads as a marker fluoroscopically. We can use every piece of information, and we did the same approach with IVUS, and these are the pacemaker leads in the SVC, and we mark the same areas that we had marked with the CT scan, and we found great correlation actually. So, and this was actually, after the deployment of the SVC and IVC valves, and this is a pullback from the SVC now into the right atrium. You can see the ventricularization of the right atrium that is expected after this procedure, and you can see there's very nice sealing at the SVC level, and there's no really tall V waves in the SVC. So the key points here are that the bicaval valve implantation is a treatment option for severe TR in patients who are too far down the disease process with large coaptation gaps and severe dilated annulus. Patients with severe TR are usually have some renal dysfunction from the congestion. And intra-procedure IVUS can be easily used to provide an accurate and actually real-time assessment of the caval size, because the caval size also depends on the volume status of the patient. So we need to be very careful when we size for these valves, and real-time sizing is always the best. We also use it to mark the key anatomic landmarks on fluoroscopy and eliminate the need for contrast administration in these patients that had CKD. And obviously, in the future, I think IVUS applications can be expanded in other structural heart procedures. We already have a few publications on use of IVUS in TAVI to study the expansion of the frame and other applications as well. I would like to thank you very much and also invite you to Miami Valves in January 2025. If you have any interesting cases, please submit, and we'll be happy to see you there. Thank you.
Excellent case, Nico. So this is a really interesting thing. So peripheral IVUS is coming again, and the trick valve, all this heterotopic valve issue. George, what's your take? Do you think we need to investigate if there is a RV reserve in these patients? Do you do a stress echo or something?
So we did the right heart catheterization. That was one of the main ways we also assessed for the RV function with the cardiac output, and also the PAPI was favorable, in this case, the pulmonary artery pulsatility index. And the patient actually was responding always very well to the diuretic, and so we thought that we had enough RV reserve to proceed.
Well, I think it's a very impressive, pathophysiologically speaking, intervention. And I have to confess, Yannis, that I support this idea because it provides actually a new physiology for the RV. It's an invert Epstein, actually. You increase the availability of volume to the RV. And with this way, you fortify the Starling substrate for the RV.
True, because you technically cause more.
Yeah,
there's more volume.
It is a volume. Well, it is an effective stimuli to increase the potency of the systolic function of the RV. The RV is much more prone than the left ventricle to the Starling phenomenon.
Yes.
So, speaking on physiological grounds, I'm very triggered to see this intervention in real life. So, Yannis?
Yes, we have to see that, in Greece it's not reimbursed. We had a couple of cases that we couldn't do because they were not covered by insurance, and the one that was covered, it was outside of the IOU because it was the 41 device. It was not is not approved yet. At least in Europe, it's not CE marked. Do you have any information, Nico, on the larger device? For the inferior vena cava?
For the inferior vena cava, no. We still had the 35 was the largest device available for the
Okay, IVC. That's interesting. Antoni, you have a comment?
Fantastic case. It's obvious that we are going to face more frequent such cases in the near future. It is obvious that not all procedures and devices are the best for each patient, so we have to better select which case is capable and which device we have to use for. And just a short question regarding the medication of the patient after the discharge. Did you change anything in your medication or regarding diuretics or something regarding the medication?
So So the one patient, the first patient, the first case I showed, actually the diuretic was decreased at 1 month follow-up. When the patient came back to see us in the office, outpatient office, the diuretic dose was less, and actually he didn't have recurrent edema, and he was doing well. He was still on a diuretic. We cannot, unfortunately, eliminate the diuretic on these cases completely. And the experience is still very limited, so we need more cases to try to understand how these patients respond more likely, long term, and yeah.
It's a fantastic case. So thank you, Nikos. Thank you very much, and I have to thank everyone that.